And I would like to start to introduce our first speaker on the topic of the second part of our meeting today, biology of therapy-related myeloid neoplasms. And this is Sara Galimberti from the University of Pisa in Italy. And Sara will talk about cytogenetics and molecular profile of TMN. So, Sara, it's all yours.
Thank you. Thank you, Connie. Hi, Charlotte. And first of all, I would thank my dear friend, Maria Teresa, for this invitation, and also Nana, Onlus, and Francesca. She's with us today, I think. My topic is cytogenetic and molecular profile of TMNs. And I think that we can define this topic as complex. I think that all agree that the genomic scenario of TMNs is complex, or probably really and very complex. You can say that it's obvious because it's the pathogenesis that causes this complex scenario. And we saw in the previous presentation that different possibilities are on the basis of this complex scenario. The first one is that some drugs that the patient received during the first neoplasm, such as occurs with topoisomerase 2 inhibitors, causes the real ruptures of chromosomes, and so translocations, and so fusion genes. The second possibility is the genomic instability. Radiation and drugs such as alkylating agents causes this instability, and we have the TP53 as a principal actor of this genomic scenario of TMNs. And the other possibility is the selection of clones with previously present mutations, such as, once again, TP53. So in the next 20 minutes, we'll do a trip starting for chromosomes through the genes mutations to the clinics, because I'm also a clinician, so I'd like to discuss the implications of chromosomal abnormalities and gene mutations in our real life. We know that the cytogenetic aberrations are found in about 80% of TMNs. So almost our patients have got one or perhaps different cytogenetic aberrations. You can see here that about 1/4, we saw the slides previous, about 1/4 of our patients present a complex karyotype. Other one have aberration of chromosome 11, but we have also some myelodysplasias or acute leukemias therapy-related that present with good prognostic karyotypes, such as the translocation 821 or inversion of the chromosome 16, or the translocation of APL. Only 15, perhaps 20% of TMNs have a normal karyotype. So you can argue that this is the problem. A complex karyotype, worse, a bad karyotype. And about 20% of TMNs are monosomal. You can see here that the chromosomes that are mostly involved are the chromosome 17. You can think to TP53, but also the chromosome 7 and the chromosome 5, monosomies or deletions. And some authors reported that probably deletions of the chromosome 5 in TMNs are different in respect of those that we know in the 5q- syndrome. And especially, they report that the most frequently deleted genes is EGR1, that is a gene very important in the myeloid differentiation. But what about the correlation between drugs or radiotherapy and the chromosomes, chromosomal abnormalities? I think that there is not a strict rule, but there are some correlations. And you can see here that the deletions of chromosome 5 or monosomy of 5 are induced by platinum, tamoxifen, topoisomerase 2 inhibitors, leuprolide that is used in the prostate carcinoma, or alkylating agents. If we move to the chromosome 7, platinum emits. This is important because emits we use all the days, and antibiotics and alkylating agents. Translocation of involving chromosome 11, alkylating agent, topoisomerase inhibitors, transplantation, and perhaps immunotherapies. And finally, the topoisomerase 2 inhibitors and the translocation involving the chromosome 21. There are some correlations, but not a strict rule. So we can also have different drugs and the same genetic chromosomal abnormalities. Some authors attempted to resume these observations and the pathogenesis, considering different genetic pathways on the basis of TMNs. And they start with the alkylating agents. Primary abnormalities we saw monosomies and deletion of 5 and 7, but you can see here in the secondary abnormalities, translocation 321, but also mutations in RAS and TP53 or trisomy. We saw that the trisomies are important. It could be better than the complex karyotype. And then epipodophylotoxins, TP53 mutations in patients with abnormalities of chromosome 11, topoisomerase 2 inhibitors, all possibilities from the FLT3 gene mutations to the good translocation 821 and inversion of chromosome 16. And finally, the normal karyotype with FLT3 and PM1 and mutations and ML gene rearrangements. So what is the problem? That the majority of patients with TML are here in the adverse risk categories: complex karyotype, monosomal karyotype, and TP53 mutations. So for this patient, we have to arrange the management of disease ab initio, to consider as the end, but soon as the end, the allogenic transplantation. And this is the problem because we heard about comorbidities, and we know that not all patients are eligible for allogenic transplantation. Another problem is, yes, we have TML. We have probably patients, the majority of patients in the high risk, but we have also translocation of 821 or inversion or PML or alpha, so they are at low risk. To have to present as TML is really different for in respect of present with de novo AML. I think that the results, the opinions are discordant, because in the Swedish cohort, the TML is significant, especially when our patient present with high risk. While in the Danish cohort, the problem is especially for good cytogenetics. We can see the good cytogenetic and probably the inversion of the chromosome 16. So what we have to think, what we have to do? We have to stratify our patient according to the Ulm 2002 classification, and to management our patient when they are TML, probably as de novo TML. But it's different to compare the Danish and the Swedish populations. As of course, one studies enroll many patients, but probably the scenario is more complicated, because each chromosomal karyotype category is characterized by a different genomic scenario, so different mutations. And we know that in about 70% of TMN, we have gene mutations. Once again, correlation between drugs and the type of gene mutations. Zinc alkaloids and IMIDs, TP53, alkylating, TET2, leuprolide, SRSF2, aromatase that are frequently used for breast cancer, SED2, and mitoxantrone and epirubicin for PMR-alpha. And finally, but not the final, the mutations of PPM1D that are induced especially by platinum and aromatase inhibitors and antibodies, especially against CD20. And very problem in our life of clinicians are TML after MPNs. I think that this is a problem, because also CPX does not well work in this category. We can use the methylating agents, but the successes are not too many. And this category of TML probably is different, because they are rich of EDH2 mutations and RSF2 mutations that represent, the first one is the Roman study. This is a Chinese study, but the significance is the same. When the patient present with mutation of SRSF2, the prognosis is bad. And do we think that these mutations, this mutational landscape would be different between TML and TMDS? Because we can observe in our real life patient with both of disease. And probably yes, you can see here that in TML, the most prevalent mutations interest FLT3 and TP53. This is a great difference in light blue TML and dark blue de novo AML. But if you see here TMDS, the differences are not so big, and probably the genes most frequently different are RANKS1, U2, AF1, and BCOR. BCOR that is together with RANKS1, one of the genes that characterize the therapy-related chronic myelomonocytic leukemias in comparison with the novo chronic myelomonocytic leukemias. And this is the mutational scenario. You can see here that at the first place, we can find TP53. At the second place is quite similar for PPM1D and FLT3. If you read the name of the mutated genes are the same that we know and that we see in the de novo MDS or de novo AML, except for PPM1D. In the last days, I revised our cases and I found only one patient with this mutation. She was a de novo acute leukemia with FLT3 mutation that received 7+3 and midostaurin. She was good. She achieved a complete response, but she had coronavirus. And after coronavirus, she suddenly relapsed. She received a FLANG, new response transplant, but she died 1 month ago after infective complication that she had after coronavirus infection. PPM1D is located on the terrible chromosome 17, is a serine protein phosphatase that acts as oncogene. Its expression is induced in a p53-dependent manner in response to various environmental stresses, such as the activation of an FKB or BRCA mutations, and plays an important role, especially in the control of and favor cancer proliferation, migration, and makes patients chemoresistant. This could be important because the chemoresistance in acute is a complex mechanism from the polymorphism of the influx and efflux pumps, PGP, ABCB1 gene or PGP protein, and we know that with the age, chemoresistance is a problem, big problem. But I think that in the future we'll hear about the PPM1D genes mutations, because this recent manuscript clearly show another further problem in our life. And it is the T-amends, and especially T therapy-related myelodysplasias that start to occur after CAR-T infusion. In this cohort of 42 patients who received the CAR-T for non-Hodgkin lymphomas, the LBCL, 17% developed T-amend. And of them, 5 had baseline clonal hematopoiesis and 2 did not. If you see the combination, you can see PPM1D in blue, TP53 in green, and diamethyltransferase in purple. And this is the problem, because the authors underline that patients with diamethyltransferase mutations present with a more inflammatory microenvironment, and they have more frequent and grade 3 or 4 CRS or ICANS. So mutations and adverse events in a setting that probably before we did not consider enough. Another setting where we can find the terrible association between TP53 and the PPM1D mutation are women. Women with previous ovarian and breast cancer. You can see here in the green the association, and with a dismal outcome. Another interesting article about the role of these gene mutations in the setting of the autotransplant in non-Hodgkin lymphomas. In this setting, mutation of PP1D can can be associated with TMNs with a worse outcome. And TP53. TP53 is a terrible gene. We know in all hematological diseases and probably also in all solid tumors. And we are starting to understand that TP53 is not only the genome guardian, but it is also able to destroy the immune microenvironment, because the mutations of TP53 increase the cytokine production, increase the myeloid suppressor cells, the mesenchymal cells, the Tregs, and are against the T cell-derived control of the tumor. And we well know that in TP53 mutated patients, blasts exhibit increased PD-ligand-1 expression. So creating another problem in the immunological control of the tumor. But we have also something of good, and about 20% of TMNs are characterized by NPM1 mutations. You can see the red and the pink circles. They represent de novo and TML both with NPM1 mutation. They are quite similar, are different from the therapy-related or de novo ML without NPM1 mutations in the principal component analysis system, but they have the same behavior from the clinical point of view. So, until now, we are convinced that the genomic landscape of TMNs is complex and that requires many research to be investigated, because we have to do NGS, we have to do PCR, we have to spend work in the labs, money, and time. So, are we sure that really we need to do that when we can only ask a patient about his or her clinical history? What do you think? I think that the problem is that we don't have a clinical indication for this population. And so we have to collaborate, to investigate, to further investigate also the biology of this patient, because I think that we have also for TML risk scoring, because our purpose is the right choice of the best patient-tailored therapy. And so what in our life all this complex landscape could induce? I think that our purpose, one possible, is the allogenic transplantation. This is the Roman against work, where allogenic transplantation is the best. But I tried here to rearrange many data, and we have also two other indications. One, use the methylating agents, in particular azacitidine, in combination with venetoclax. The complete response rate are similar between TML and de novo AML. So, a good news. And if you see the CPX, we have the similar complete responses and at least a better median overall survival. So we have something to treat our patient with TML. But the problem still is the TP53 mutations, because we can see that also the new approach with the cytabine 10 days in combination with venetoclax is not so good. And also CPX that functions against the majority of mutations, including FLT3, is not good for TP53 mutated patients. And so we have to work again. We have to go to reach and to participate to clinical trials with drugs able to restore wild-type function of TP53, such as inhibitors of MDM2 nucleins. Or we can also believe in other drugs that are able to degrade mutant TP53, such as APRIL. And we have probably to combine the classic therapeutic approaches to the new, in particular against the immunity for restoring a correct immunological control of disease, or using the checkpoint inhibitors that in combination with the methylating agents offer about 30% of overall response rate and 20% of complete responses. And the future is probably the inhibitor of PPM1D. GSK propose this drug that in vitro setting could seems to be more active if combined with nucleins. So what about our problem? The problem is evident. The genomic landscape of TMS is very complex, with usually a bad prognostic impact. We know that genetic aberrations are found in the majority of our patients. We attempt to correlate the type of antecedent therapy to genomic aberration, but not everywhere we can. And we must characterize by genetic point of view our patient, because we need a precise risk score definition for the choice of the best treatment, but especially we have to study it to meet again for identifying new target therapies. So in the meanwhile, I would thank you for attention. I'm here for questions. Thank you.
Thank you very much, Sarah, for this really good overview on the complexity and the difficulties and the challenges with this TMN. So are there questions from the audience? So maybe I start with a provocative question. Yeah. I mean, you raised it in your talk. We do know that these therapy-related MN, that they are associated with a poor prognosis, despite the fact that we do also see the same genes that we do see in de novo AML, but there is a difference with regard to prognosis. So is there, how do you see the beneficial effect of doing such a comprehensive genetic screening in these patients, and not saying this is an AML or a myeloid disease that is therapy related and is associated per se with a poor prognosis, and we should go straight forward to an intensive treatment that means allogeneic stem cell transplantation?
I think yes, because you demonstrated that FLT3 mutations are in the intermediate risk, and so we have the majority of patients probably in the high risk, so or transplant or the methylating transplant is not feasible. But I think that we have an intermediate part of this problem that we have to manage, probably, I think, with more aggressive approach than de novo AML, because the intermediate risk patients are the difficult to be treated. we use transplantation or not. The MRD could be, but MRD is good in this population or not. Probably, I think that if we believe that TMNs are equal major rate of resistance, probably this patient will not achieve MRD negativity. And so, when possible, they will go to the transplantation.
Yeah.
Can I,
Maybe one comment to that. I think we cannot translate the ELN risk stratification from the ELN one-to-one to the therapy-related N cases. I think this is a very important issue, and this is also true for elderly patients.
Yeah.
This is not really translatable one by one, because the ELN risk stratification has been performed in younger patients who have
intensive
been treated.
therapy.
Exactly,
Yeah.
exactly. And I think we more and more learn now that in the elderly patients that have been treated with other treatments, that the ELN risk categorization is not of prognostic relevance anymore. It would be really important to see what kind of genetic risk classification is possible for these TMN cases.
And in Genoa, with Genoa, they performed experiment with functional experiment about TP53 mutations, and I remember before. And while in the CLL, TP53 mutations are different from the functional point of view, so some bad, some good. We sent them our MDS, not AML, MDS samples, and they demonstrated that all TP53 mutations were bad, not good, differently from CLL. So probably also TP53 are not the same mutations in all disease and all patients.
Yeah, Stefan.
Thank you, Sarah, for this very inspiring talk. I have a question regarding to the TMNs after CAR T cell therapy. So did the authors look also whether the PM1D mutation was present before the CAR T cell infusion? And is that more the CAR T cell therapy like creating an immune suppressive environment with stress hematopoiesis, which is a favorable environment for a clone emerging, or is it really induced by, well, it's just fludarabine, 3 days, cyclophosphamide, so it's not that potent therapy, cytotoxic therapy.
The authors stress at this point because they had some patient, 5 with previous mutations and 2 without, and we don't know. But this is a problem because the time from the infusion of CAR T infusion to amends are not 5-10 years, because it's 2 years, 1 year, and so it's in the past we had a patient with follicular lymphoma that received Zevalin. Do you remember Zevalin?
Yeah.
Okay.
We didn't use that.
Okay. Zevalin, and after 1 year, she developed acute leukemia and she died in a few days. So I don't know.
Yeah, we also observed a heavily pre-treated patient, of course, for lymphoma, which developed secondary or therapy-related after CAR T. So it's, yeah.
I think that we have to see what will occur with bispecific and new antibodies, because many antibodies has a drug that deliver in the cell, and we don't know if this will be probably be a problem, such the anthracyclines or pipidophylotoxins or classic drugs.
Sarah, there is one question from my co-chair.
Yeah.
Yeah. Charlotte, you raised your hand.
Thank you. Can you hear me? It was a wonderful talk, great overview. I have a question concerning P53. Having a single P53 mutation is bad, but having multiple is even worse. Can you comment on the multiple hits, P53 mutations in secondary AML and MDS?
If a different number of TP53 mutations,
Exactly.
yes.
Yeah.
Yes, Charlotte, there is true. And the patient with multiple high hit risk are more than one TP53 mutations and VAF major than 60%. This is a definition of high hit risk in TP53 mutated patients. It's true.
So I think that, oh, there's another question, sorry.
Thank you very much for your overview. My question is about the cells, about the mutations that we see in the cells. Do we sort CD34 positive stem cells and check if the cells have P53 mutation or not?
I don't know. In my lab, we don't sort, but probably if you consider your results in the subclones and different, there was not TP53, but FLT3 in your data, yes. But probably we can suppose that the mechanism could be the same. What do you think, Maria Teresa? Because the FLT3 is educational in this.
Well, I think since we have, I mean, many of these cases, and I think Emiliano will talk about this, have clonal hematopoiesis underlying also before treatment for the primary tumor. We haven't done CD34 selection, but I suppose that clonal, of course, clonal hematopoiesis will be in the stem cells, in the hematopoietic stem cells, which then receive the chemotherapy, and they, you know, if they are damaged by chemotherapy, and so then afterwards these cells are going to expand as a therapy-related AML. But I mean, this is a very good point.
Yeah.
We didn't do that.
Yeah, and what is the precursor, the real precursor? Because CD34 is one, but we can also suppose CD26 or other markers as a real leukemic stem cell. We don't know.
Okay, thank you very much. And I have one more question. I think if I didn't misunderstand, you talked about the relapse after coronavirus infection. There is a trend, in my opinion. There are people coming, they have relapses or they have de novo acute leukemias after the vaccination and after COVID-19 infection. Do you also observe these kinds of?
Yes,
patients?
we had the last year 5 patients that were in CR with AML, that were in CR, that suddenly relapse, not after vaccination, but after coronavirus infection. And we suppose that the immune system probably was able to control the disease, and with coronavirus infection, it translocated to against coronavirus and then left the control of leukemia, because it's impossible to believe that a patient in CR suddenly relapse. We thought so, but I don't know.
Yeah, this shows us that it's very important that we really collect such data in a really structured way to answer such questions.
Yeah.
Sarah, I thank you very
Thank
much
you.
for